Identification and management of maternal sepsis during and following pregnancy. Green Top Guideline number 64 is the topic of our discussion today. All women are at risk of sepsis during pregnancy and in postpartum period. During pregnancy and postpartum period, clinicians should be aware of and be able to recognize the risk factors for developing the maternal sepsis. Women at risk of sepsis in pregnancy should be made aware of this and provided information, including access to the care to reduce the risk. What are the common organisms causing sepsis? Those include E. coli, Group B, hemolytic streptococcus, anaerobes, staphylococcus aureus, group A beta hemolytic streptococcus, coliform and other E. coli, Haemophilus influenzae and Listeria monocytogenes. The risk factors for developing maternal sepsis during pregnancy and postpartum include the maternal risk factors like obesity, diabetes in pregnancy, iron deficiency anemia, maternal age of more than 35, impaired immunity or immunosuppressive medications, women of ethnic minority, renal, cardiac or liver disease, history of pelvic infection, contact with GAS or IV drug use. The obstetric risk factors include prolonged rupture of membrane, cesarean birth, vaginal trauma, retained pregnancy tissue, amniocentesis and other invasive procedures, multiple gestation, and cervical cerclage. What are the likely causes of sepsis outside the genital tract and how might they be identified? A thorough history is recommended as soon as possible after presentation, and an appropriate physical examination should be offered. Consider investigation other than non-infective causes that can masquerade as sepsis. Recognize maternal sepsis. What should prompt recognition of sepsis? Consider sepsis as a possible diagnosis in all women during pregnancy and in postpartum period with a suspected infection and whose clinical condition rapidly deteriorates. Potential sites of sepsis outside the genital tract and clinical features of their presentation include the head site, which include diseases like meningitis or meningoencephalitis, and patient presents with photophobia, neck stiffness, altered conscious level, delirium, focal neurology, and seizures. When ear, nose, and throat are involved, the diseases that should be suspected include otitis media, sinusitis, pharyngitis, or laryngitis, and the clinical features include earache, muffled hearing, purulent nasal discharge, facial pain, headache, sore throat, cervical lymphadenopathy, and the hoarse voice. When the chest is involved, we should consider pneumonia, both viral and bacteria. Clinical features include cough with a sputum, that is more likely bacterial, hypoxia, and pleuritic pain. When the cardiac site is involved, the possible causes include infective endocarditis with the clinical features like regurgitant murmur, embolic lesion, splinter hemorrhages, and Janvey lesions. When hepatobiliary area is involved, the diseases include cholecystitis, cholangitis, and pancreatitis. The clinical features include right upper quadrant pain, Murphy's sign, positive for cholecystitis, upper abdominal pain radiating to back. When the abdomen is involved, the possible causes include gastroenteritis, appendicitis. The bowel perforation is more common in inflammatory bowel disease, and the clinical features include diarrhea, vomiting, McBurney's sign for appendicitis, atypical presentation common in pregnancy, that is acute abdomen. Although McBurney's sign is the atypical presentation. When the breasts are involved, we should suspect mastitis, and patient may present with inflamed breast, pain, and features of sepsis and bruising. In case of urinary tract involvement, we should suspect UTI, pyelonephritis, and cord genital herpes. Patient present with dysuria, loin pain, back pain, hematuria, and acute urinary retention. When the regional anesthetic blockage related infection is there, we should suspect meningitis or spinal sepsis. In that case, patient present with headache, photophobia, back pain, focal neurology, permanent spinal cord or cauda damage may result if neural compression is not relieved urgently. In case of the wound infection, suspect peripheral cannula phlebitis, cesarean birth, or episiotomy wounds. Patient may present with skin and soft tissue infection. These are particularly associated with the toxic shock syndrome. Other features include rash and conjunctival redness. In case of necrotizing fasciitis, suspect early necrotizing fasciitis that can be deep in the tissue, and the cardinal feature is of agonizing pain, typically necessitating increasing amount of analgesia culminating in opioids. There may be no skin changes early on. Later, ascending infection to the skin is there, producing blister and frank necrosis. The non-infective causes that can masquerade sepsis include the diseases like the blood transfusion reaction. Patient present with pyrexia and rash. Autoimmune disease presents with pyrexia. Patient with acute fatty liver or pregnancy presents with pyrexia. In case of disseminated malignancy, the clinical feature include pyrexia. In case of thrombotic thrombocytopenia, patient may present with pyrexia, acute renal failure, altered consciousness, thrombocytopenia. In case of hemorrhagic lymphocytosis, Lymphoschistiosis, patient presents with pyrexia, pancytopenia, lymphadenopathy, and rash. In case of the occult bleeding, patient presents with hypothermia, raised lactate, and shock. In patients with epidural related maternal fever, patient may present with pyrexia. In case of misoprostol side effect, patient may present with pyrexia. Now, the clinical symptoms, signs, and the risk factors suggestive of sepsis during pregnancy and postpartum include certain red flag or features in the pregnancy with suspected sepsis that indicate the high risk of the sepsis. And those include objective evidence of the altered mental state in which GCS is less than 15. Respiratory rate is equal to or more than 25 breaths per minute. Oxygen saturation less than 94% on room air. Heart rate is more than 130 beats per minute. Blood pressure, systolic blood pressure is less than 90 millimeter of mercury, and urine output. Either patient has not passed urine for more than 24 hours, or if catheterized, less than 0.5 ml per kg urine per hour is the output. The amber features include behavioral mental state change, acute deterioration in the functional ability, respiratory rate of 21 to 24 breaths per minute, heart rate of 100 to 130 beats per minute, systolic BP of 91 to 100, urine output either not passed in the last 12 hours or if catheterized 0.5 to 1 ml per kg. Has had invasive procedure in the last 6 weeks, impaired immune system, temperature of less than 36 or more than 38, and current diabetes or gestational diabetes, close contact with GAS, prolonged rupture of membrane, prolonged vaginal bleeding and abdominal pain post-birth, and offensive vaginal discharge. What is the optimum way to monitor women with the suspected sepsis? Monitoring of women with suspected sepsis should be performed using early warning system modified for obstetric, managed through a multidisciplinary approach with early escalation and senior input. Now, what are the common investigations when sepsis is suspected? Blood cultures are the key investigation, and 2 sets should be obtained prior to antibiotic administration. However, antibiotic treatment should be started without waiting for microbiology results, and consider HSV polymerase chain reaction when indicated. Blood cultures are in fact the key investigations, and serum lactate should be measured urgently in women with the features making them at high risk of sepsis. Serum lactate of 4 millimole per liter or more should prompt immediate escalation of the care, including consideration of discussion with a critical care team. Any relevant imaging studies should be performed promptly to confirm the source of infection, and these may include a pelvic ultrasound scan or computerized tomography scan if pelvic abscess is suspected, or chest x-ray for the possible chest pathology. Other microbiological samples should be taken by clinician, and that should be guided by clinical suspicion of the focus of infection as appropriate. Routine blood test should include full blood count, coagulation screen, urea electrolyte, creatinine, liver function test, CRP, the venous blood gases or other near patient testing for glucose and lactate. Appropriate virology testing, including SARS CoV-2 testing, should be undertaken if indicated. Now, any woman who is unwell with the symptoms of tonsillitis, pharyngitis should have throat swab sent for bacterial culture. If MRSA status of woman is unknown, a pre-moistened nose swab should be sent for rapid MRSA screening where such testing is available. Now, here we have surviving sepsis campaign, 1 hour bundle of care elements, which include measure lactate level, obtain blood culture before administering antibiotics, administer broad spectrum antibiotics, and begin rapid administration of 30 ml per kg crystallite for hypotension or lactate of equal to or more than 4 millimole per liter. Apply vasopressive during and after fluid resuscitation to maintain the mean arterial pressure of equal to or more than 65 millimeter of mercury. Now, points to note in the history regarding infection that might suggest the cause of infection include febrile illness, chills, rigor, and myalgia. And microbiological consideration includes staphylococcus, streptococcal bacteremia, especially if wound or rash is there. Gram-negative infections, consider influenza, HSV, SARS, CoV-2 adenoviral infections in these different conditions which are listed here. If there is history of contact with GAS and patient presents with impetigo, tonsillitis, cellulitis, flu-like symptoms, then consider GAS. If the history is suggestive of recurrent skin infection, then we should take detailed history. If there is history of abscess or severe mastitis, then we should consider Pantone Valentine leukocidin PBL related Staphylococcus aureus. In fact, PBL is a toxin produced by a certain strain of Staph aureus. If history is suggestive of severe respiratory infection or hemoptysis, or there are cavitation and massive fluid, then there is microbiological consideration of tuberculosis, Staph aureus, or necrotizing pneumonia PBL producing Staph aureus. In case of dysuria and flank pain, check recent antimicrobial treatment. In case of acute urinary retention and symptoms like dysuria and sacral pain or paresthesia, consider HSV. In case of intravenous drug misuse and septic emboli and stigmata of endocarditis, consider GAS. In case of the gastroenteritis and symptoms like diarrhea, vomiting, consider different pathogens like Salmonella, Campylobacter species. In case of zoonotic infections and exposure to animals with diarrhea, consider Salmonella, Campylobacter, C. diff, and Cryptosporidium. When there is history of infection with multi-resistant organism, discuss urgently with infection specialist. In case of hemorrhagic Russian purpura, discuss urgently with infection specialist, and stringent infection control precautions should be there. In case of allergies, obtain careful allergy history and avoid all the irritants which produces allergic reactions. Now, what are the appropriate triggers for the involvement of other specialties and who should be involved? Senior clinicians, including obstetrician and obstetric anesthetist and senior midwife, should be directly involved in the decision to escalate care within 1 hour of any deterioration. Expert multidisciplinary advice should be sought urgently at a senior level when sepsis is suspected and not responding to initial management. Now, there should be an urgent referral to the critical care team in the severe or rapidly deteriorating cases of the sepsis where facilities or skills to care of a woman are not available on maternity unit. How should maternal sepsis be managed? Administration of the intravenous broad spectrum antibiotic is recommended within 1 hour in the woman at high risk of the sepsis with or without septic shock. Use of the sepsis bundle may improve the compliance with urgent management in the woman at high risk of the sepsis. Early fluid resuscitation of the crystallite should be administered with an immediate 500 ml fluid bolus in women with hypotensive or elevated serum lactate level of 4 millimole per liter, and this may need repeating. Now, choice of empirical antibiotic therapy should be guided by local epidemiology, reflecting the incidence of resistant organism within that geographical area. For the life-threatening sepsis, where the sensitivity of the organism is unknown, a combination of either piperacillin tazobactam, that is tazocin with the brand name, and meropenem for gram-negative cover, plus clindamycin for gram-positive and anaerobic organism provide a very broad cover. But local guidelines should be consulted and discussed if the history of multi-resistant organisms is there. With any history of MRSA in women with a sepsis, the addition of vancomycin is advised. Empirical antimicrobial should be reviewed with the culture results and targeted oral agent used as soon as clinically appropriate. If a change in antibiotic regime is considered because of deterioration despite the first line treatment, consider the addition of IV acyclovir 500 mg 8 hourly as a part of the second line regime. Regular senior clinical review is recommended. Now, what are the indications for transfer to the intensive care unit, which includes certain cardiovascular features, which you can see here, the respiratory features like pulmonary edema and others, renal features, and the neurologicals like decreased conscious level, and miscellaneous features, which you can see in this table. Only 0.03% to 0.06% of pregnant women have perineal colonization with group A streptococci and are usually asymptomatic. Necrotizing fasciitis. Post-birth wound infection can lead to serious abdominal or remote necrotizing fasciitis. Now, antimicrobial choices and limitation of antimicrobial spectrum is shown in this table, which include the co-amoxiclav, which has got no activity against the MRSA. Metronidazole only covers anaerobes. Clindamycin is currently in practice in UK that covers most of the GAS, GBS, but it is associated with increased risk of C. diff superinfection. Piperacillin and tazobactam with the brand name of tazocin by the Pfizer. Spectrum is same as co-amoxiclav, but also many gram-positive and gram-negative organisms, including Pseudomonas, are covered with tazocin. No activity against MRSA. And avoid in beta-lactam allergy. Now, cephalosporin, for example, ceftriaxone, has got no activity against Epstein extended spectrum beta-lactam producing Enterobacteriaceae. And with this antibiotic, there is increased risk of C. diff. Carbapenems, very broad empirical cover, most gram-negatives cover most gram-positive except MRSA. And it is not for severe beta-lactam allergy. Gentamicin is mainly for the gram-negative cover, including Pseudomonas, and no streptococcal or anaerobic cover is there. The main disadvantage is that it is nephrotoxic and ototoxic. The vancomycin covers MRSA, and serum level needs to be monitored due to the potential for renal and ototoxicity. Antimicrobial management of sepsis. For empirical therapy of life-threatening sepsis, a combination of either piperacillin, tazobactam, or meropenem plus clindamycin provide the broad spectrum cover, but it lacks the guaranteed MRSA cover. Intravenous immunoglobulin should be considered as a part of treatment for gram-negative necrotizing infection and toxic shock when other measures are failing. How should the fetus be monitored and timing and mood of the birth be decided? In a critical ill pregnant woman, birth of the baby may be expedited if it would be beneficial to the woman or the baby or to the both. A decision on the timing and the mood of the birth should be made by a senior obstetrician following the discussion with the woman and or her family if her condition permits. If preterm birth is anticipated, magnesium sulfate should be considered if indicated, and consideration should be given to the use of antenatal corticosteroid for the lung maturity in a woman with a sepsis. During intrapartum period, continuous electronic fetal monitoring is recommended. An individual risk assessment should be made by the senior anesthetist with regard to the type of anesthesia as well as the need for invasive monitoring. What are the neonatal issues that must be considered? Baby of the woman treated for sepsis during labor or in 24-hour period before the birth require assessment for the risk factors and clinical indicators of neonatal infection. If either the woman or the baby is infected with group A streptococcal disease in the postpartum period, both should be treated with antibiotics. What postnatal care and or infection control issues should be considered? All women, pregnant women and women who have recently given birth should be informed of the signs and symptoms of genital tract infection. Any group A streptococcal infection identified during pregnancy should be treated aggressively, and full infection control precautions adopted including barrier nursing as per local guideline. Close household contact of the woman with group A streptococcal infection should be warned to seek medical attention should the signs and symptoms develop and may warrant the antibiotic prophylaxis. Healthcare workers who have been exposed to respiratory secretions of women with GS infections should be considered for the antibiotic prophylaxis. Now, improving the outcomes for maternal sepsis. Can sepsis be prevented or detected earlier? All pregnant women and women who have recently given birth should be informed of the signs and symptoms of the sepsis. Healthcare professionals should have a low threshold for suspecting sepsis. Now, what education and training should be provided to the healthcare providers to improve the maternal sepsis care? Regular multidisciplinary teaching should be provided to all healthcare professionals involved in caring for the woman with the sepsis. And here we have the sequential organ failure assessment score, that is the SOFA score, which includes the different parameters for the respiration, coagulation, liver or bilirubin, and the cardiovascular features, neurological features according to Glasgow Coma scales, and the renal features in which we measure the serum creatinine level and we give score accordingly. So this is called the SOFA score. Now here we have example of the maternal sepsis risk stratification tool. And here we have example of maternal sepsis bundle action tool. And here the antibiotic spectrum has been shown. So that was all about the summary of bacterial sepsis during and after pregnancy, the latest RCOG guideline. Subscribe on Obs and Gynae and comment in the comment section of this video, and follow the Facebook page of on Obs and Gynae.